and you'll hear from my other good friend and colleague, Mr. Hassan, shortly. And Mr. Halim asked me to speak about cervical trauma today. So I'm going to share my screen with you now. Hopefully everyone can see that. Now, cervical trauma, we've got 10 minutes to talk about it, and then we've got some questions. So I'm going to give you some principles, then some common examples that you might find in the Viva or the to discuss. So this is how we're going to do it. We're going to talk about the treatment principles, which I believe you can apply to most trauma, whether it's of the cervical, thoracic, or lumbar spine. We'll discuss 3 cases, some common cases that you might get in your Viva, and then there'll be the opportunity for questions. So if there's one slide I want you to remember, it's this slide. When you get shown a picture of a cervical injury, maybe a CT or an MR or an X-ray, I want you to think about the management as these principles. So number 1 is ATLS management of the patient. And you could talk about that for 2 to 3 minutes, which is a great use of your time. Number 2 is to assess the neurological status of the patient. And we use an ASIA chart, which grades which forms a neurological level, for example, C5, and a level of disability, usually graded on A to E, depending on whether it's a complete or incomplete injury. You should then think, have I got the appropriate imaging to manage this patient? And virtually all cervical trauma requires a CT and an MRI. Look for dislocations. If there's dislocations present, you want to reduce them and reduce them early. And then if the injury is unstable, based on a physiological definition that we'll go through, you want to stabilize unstable injuries, which can be operative or non-operative. So these 5 principles will allow you to manage any trauma injury of the cervical, thoracic, or lumbar spine to pass your Viva. All right, so just remember, if you take one thing away, I want you to remember this slide. So this is the first case. We're going to go through the principles of what I've just taught you in 3 cases. 78-year-old female, fall from a standing height, neurologically intact, past history of osteopenia. She's normally a good 78-year-old who can walk and mobilize. This is the imaging. I don't know if anyone is able to tell me what the injury is, or if they wish to speak. Okay, I'll just mention it. It's a peg fracture. You may be able to identify the injury on my screen here and here. Some of you may be able to classify the injury as a type 2 peg fracture, which is very common in the elderly. But most importantly, I want you to go through the management principles. So principle 1, ATLS management of the patient. ATLS management, are there chest injuries? Has this lady got rib fractures that mandate some oxygenation therapy? You need to treat hypoxia and hypertension first. ATLS management of the patient. Don't focus on the peg fracture. Number 2, assess neurology. We've told this lady is neurologically intact. Principle 3, obtain imaging. I've said pretty much all the patients require a CT and an MRI. On this particular case, you may not wish to have an MRI, but if you are going to operate, and Mr. Hassan is who's on next, is a very competent and skilled cervical surgeon, I'm sure if you asked him, he'd want an MRI. Number 3, reduce dislocations. There isn't a dislocation here to reduce. And number 4 or 5, stabilize an unstable injury. Usually type 2 peg fractures are stable, therefore we can stabilize them without surgery. It usually requires a collar. It can be a soft or a hard collar. So they're the 5 principles. We've gone through it with a case. Here we are again, ATLS, assess the neurology, image the patient, reduce any dislocation, stabilize. So you can see I've talked for about 3 or 4 minutes on just a peg fracture in an elderly patient. So you can imagine if you could easily detail in the Viva a good 10-minute description of this, just a simple peg fracture. The last point, what is the definition of spinal stability? I don't want you to give radiological definitions. I find that unhelpful. It's the ability of the spine under physiological load, meaning the weight of the patient, to withstand an element of displacement that causes pain, neurological injury, or significant deformity. Now, this lady doesn't have significant pain. She doesn't have significant deformity. She doesn't have any neurology. Therefore, we don't need to think about operative management here. Next case, 21-year-old male, quad bike racer, flipped off his bike, injured his neck, not moving his hands or legs, and he's got a flail chest. I want you to, before I show you the next slide, I want you to think the 5 principles of management here. Number 1, ATLS, he's got a flail chest. That is the priority for treatment. Number 2, assess his neurology, not moving his hands. That suggests a spinal cord injury, potentially with an injured neck. Number 3, image. What imaging would you want to see? Well, we said pretty much all patients require a CT and an MRI. Number 4, reduce any dislocations, and number 5, stabilize injuries. So here is a CT. I'll give you a second to look at it. You will see at the C2, 3, 4, 5, 6 level, there is a displacement. And the picture on the right shows the facets. And you can see that one of the facets is locked. It's moved out of position. Now, this is moved more than 50% displacement of one vertebral body on the other. Therefore, we call this a bifacet dislocation. If it was just between 0 to 25, it would probably be more in keeping with a unifacet. But you could ask to see the facets on the CT. So thinking about our process, what's the first thing we do? We manage the ATLS, we assess the neurology, we obtain imaging. Would you be happy with the CT only? I would ask the examiner for a further investigation, which you saw already, an MRI. This shows the spinal cord being pressed on by the displaced vertebra. And you'll see there is some cord signal change. So if you look at the cord, the color of the cord, the level of the fracture, there is an increased, should we say, high intensity whiteness in the cord, suggesting a spinal cord injury. Compare that to the brain stem and the lower cord. So principles, remember, 1, 8, I'm banging this home so that you can talk about this till the cows come home. Number 1, ATLS. You can talk for 2 to 3 minutes on this patient on ATLS for your Viva. I'm going to manage this patient. I'm going to assess ATLS principles. I'm going to give him oxygen. I'm going to manage his blood pressure, because the treatment for this spinal cord injury is not to reduce and fix. It's to manage the blood pressure and to manage the hypoxia. His best chance of having a cord that functions is not to operate. It's to give it blood and oxygen. So that's ATLS. So we treat his flail chest. We optimize his, what we call the MAP, mean arterial pressure, which in spinal cord injury is about 85. So that's ITU. So you need to get the ITU guys down. And then you think, well, he's not moving. I've imaged him now. I've managed him through ATLS. I've optimized his blood pressure. I've optimized his oxygen. I've got my CT. I've got my MRI. What's the next thing we do? It's to reduce dislocations. We said it's a dislocation because it's over 50% displaced. So the next thing I want you to think is, how would you do it and where would you do it? Some people would do it on the ward. Some people would do it in theatre. How would you do it? The special device called Gardner-Welds Tongs. There's no right or wrong answer. It's just, what would you do? So you could easily manage this injury like this. The patient is on the ward. You place these Gardner-Wells tongs with these nuts and bolts into the side of the head, just above the ear, on both sides, and you apply gentle weights. You can see here the weights pulling the patient's head up, and the patient's body is down, so it gives a balanced weight pulling, so the patient doesn't get pulled off the bed. And you gently increase the weights, and you reassess the neurology. Now, if the patient is should we say, obtunded or unconscious, you can't do that. You may go straight to theatre. but you could potentially do it on the ward, regularly assessing the neurology. If the neurology changes, you'll have to go straight in, decompress with an operation. But it's perfectly reasonable to decompress to reduce this dislocation through traction on the ward and assess the neurology. Other people may take the patient to theatre, reduce it with these tongs, and then go in and stabilize. But that's principle 5. So this is the definitive stabilization. That's how we reduce it on the ward or in theatre, assessing the neurology, and then we stabilize it, principle 5, because this is an unstable injury because it's so displaced, it's a dislocation. The operation we do is an ACDF, anterior cervical decompression and fusion. This is one of 2 operations you will be required to describe. One will be a lumbar decompression for cauda equina. The second is an anterior cervical discectomy and fusion. It's a great anatomy question. I don't have time to go through it in this presentation, but that's only one of the 2 operations you would be required to know about. ACDF, anterior cervical discectomy and fusion, mainly the consent processes and the approach. Case 3, the final case. This is an unusual case. You are not going to get this in your Viva, but it's simply to demonstrate how you can apply principles to any case you get in your Viva, so you're not going to be phased. 45 Burmese, this is a case I got in Australia, 45 Burmese refugee, had a road traffic accident, unconscious at the scene. Principle 1, we know ATLS. GCS at the scene, not moving limbs, so intubated, give oxygen to the patient. Then we do ATLS assessment, which is the trauma CT. Always ask for the trauma CT. That's a CT, chest, abdomen, pelvis, head and neck. That's 3 minutes into your Viva. You've chatted about nothing to do with the injury, but important management steps. This is the injury. I'll talk for 2 more minutes. Is that okay, guys? Have 2 more minutes? There's an injury here. It's a tricky injury to spot. I'll give you a clue. It's at the top. It's at the top of the spine. Can anyone spot it? It's a dislocation of the occiput from the C1. We call it an occipitocervical dislocation, a high cervical trauma. If you get anything that's up that you haven't learned for, remember the 5 principles. ATLS, you've spoken for 3 minutes. Number 2, assess the neurology. Patient unconscious, you can't do that. Number 3, what was principle 3? Image the patient. Well, we've got the trauma CT. What's the next investigation we want? An MRI, ask for that. Number 4, reduce dislocations. This is a dislocation. We need to reduce it ideally. Number 5, stabilize if unstable. So this was the trauma CT. This is why ATLS is so important. The patient had an abdominal bleed. What do we do first, the neck or the abdominal bleed? Well, to treat the neck, we treat hypoxia and hypertension. We deal with the bleed first. The patient went, I was involved in this case in Australia. The patient went to theatre, had a laparotomy, bleed dealt with. Subarachnoid hemorrhage it was managed non-operatively, and then we reduced the dislocation and stabilize. We call it an occipitocervical dislocation. You don't need to worry about this. Just think of the principles. This is the key slide. ATLS, you can talk for 3 or 4 minutes. You're not jumping in to stabilize the neck. You're managing the ATLS principles. This is what the examiner will want from you. They'll want to show that you can be a consultant and you can safely manage patients. And the outcome of this patient was disastrous, just in case any of you are wondering. The patient had locked-in syndrome, meaning the patient was cerebrally okay, but the spinal cord injury was of such severity that the patient had no movement in the arms or limbs, so was literally locked in, requiring lifelong care. But that's an ethical question. So conclusion, cervical trauma. Remember this slide. ATLS, manage hypoxia and hypertension. 2, assess neurology. 3, image with a CT and MR. 4, reduce dislocations. 5, stabilize and stable injuries. 6, rehab. I've added a final one in. Any trauma that you see of any spinal bone from the head down to the sacrum that you are unsure about the management of, detail this. That's all you need to remember. And you will be able to talk for 10 minutes competently, like a consultant, to pass that Viva station. Thank you, guys. I'm going to pass my back to my good friend and colleague, Mr. Halim, now to take questions.
Thank you, Matt. That's excellent, especially for the candidate who may not know what's happening, but following a sieve will still provide a safe, competent, and coherent answer and enough to pass the exam. I think that's wonderful. Questions are going to be in the end. I think now we're going to carry on with Mr. Faisal Hassan, who will speak about Coda equina syndrome, please. Thank you very much.
Thank you, Shah and Boaz, for giving me the opportunity to come and speak. So I'm Faisal Hassan. I'm one of the spine neurosurgeons from Royal Orthopedic Hospital, Birmingham. So today, my topic is Coda equina syndrome. It is quite a well-known topic, but unfortunately, it is one of the most controversial topic in spine surgery. So what are the objectives of today's talk? What is meant by Coda equina syndrome? History and examination, investigation, management, especially when to operate, outcome of the patient, and some medical legal perspective. So Coda equina, we all know it is the collective term given to the nerve roots distal to the conus medullaris, which is occupied the lumbar system. The name comes from the Latin horsetail, and the nerves in Coda equina supply and innervate the pelvic organs, internal and external sphincter, both bladder and bowel, perineal sensation, and the lower limb function. It is the two British surgeon, in fact, Mixter and Barr, mentioned about the term of Coda equina syndrome in 1934. But one thing we must remember that Coda equina syndrome is a clinical diagnosis. It is not an radiological diagnosis. So what is meant by Coda equina syndrome? So its syndrome is referred to a collection of symptoms and signs that results from the severe compression of the descending lumbosacral nerve roots, or basically impairment of the Coda equina function. It is an ongoing process: compression, disturbance of the blood supply, ischemia, the loss of function of the affected nerve means loss of function of the organs supplied by that specific nerve. So it is lumbar disc herniation is the most common cause of Coda equina syndrome, and up to 2% of lumbar disc may cause the syndrome. But we should always remember the other causes of Coda equina syndrome, like a severe canal stenosis, severe listhesis, metastatic, benign tumor like a schwannoma, infective, traumatic, or even a post-op hematoma may present with Coda equina syndrome. So history. So we have to be back to the basics. So we need to take a proper history from the patient. And during the history, we must emphasize on two things. Number one, the onset and progression of the symptoms, which is very, very important. We will discuss later on. And the history to rule out the other causes of the Coda equina syndrome, patient known to a prostate med, etc. So the patient will complain about low back pain, which is called common, unilateral or bilateral leg pain. There might be lumbosacral root sensory deficit, might be lower extremity weakness, but these two are the most important: the perineal sensory disturbance and some form of urological dysfunction. So up to 90% of patients may present with some form of urological dysfunction. Examination. So again, a thorough neurological examination should be carried out, and we encourage to use ASIA chart, American Spinal Injury Association chart. We all know and we all seen about the chart, and we always encourage to use the ASIA chart. Catheter tag. It is when the patient is catheterized, then we pull the catheter. There is some controversy. What is actually meant by catheter tag? Is it the just filling of catheter inside, or it is the desire to urinate when you pull the catheter and the catheter irritates the trigone area? Basically, it will be the desire to urinate, not just kind of filling of some pool, but that is also act as some form of sign that the bladder sensation is still intact. The other examination is very important, is rectal examination. We look for saddle numbness, anal tone, and squeeze. But unfortunately, this rectal examination has got very little accuracy in suspected cauda syndrome. And we also remember that one, absence of anal tone is in fact a very, very late sign. So various studies has been performed to check the accuracy of the DRE. And there's one paper, Gooding, found that one, it has no significant value in acute diagnosis of cauda syndrome. P-value is quite low. Balasubramaniam is again a nice paper, had found that the saddle sensory deficit has got most higher predictive value than any other clinical features of diagnosis of CES. But we should remember that one, no single signs or symptoms has got absolute predictive value in establishing the diagnosis of cauda syndrome. All these signs and symptoms act as an adjunct to our diagnosis of cauda syndrome. One thing is worth remembering that one, the discrepancy between the sacral dermatome. You can see in one picture, the S1 ends below the knee and S2 ending below the buttock. But in other published book, S1 and S2 all the way goes into the perineal and buttock area. So if a patient has got a large L5S1 disc bulge, they may present with some numbness in the perineal area, but in those cases, mainly an unilateral one rather than a circumferential one, according to me. So classification. Various people has tried to classify cauda syndrome, and a lot of time we use this term complete and incomplete cauda syndrome. In the incomplete one, there is some form of urgency or decreased urinary sensation, but without any true incontinence or retention. In the complete one, there's a complete loss of function of bladder bowel and sexual one. Gleave and McFarlane, again, two spine surgeons from UK, has classified cauda in kind of in 4 category. CESI, incomplete. There is some impairment of bladder function, like a sensation loss, loss of desire to void, poor stream, strain to micturate, and CESR, when the loss of bladder function, painless retention urinary flow. He also classified as CESS, kind of a suspected, and CESC means complete. In this one, there's no bladder, bowel, or sexual function. This CESI and CESR are the most important in our clinical practice. So now come to investigations. We all know the MRI is the investigation of choice, if not CT scan, if MRI is contraindicated. And according to BIOS, the MRI scan should be performed at the local hospital. We know not all the hospital has got 24-hour MRI service. In that case, there must be a local policy or protocol to the local or regional spinal unit when those patient needs an overnight MRI scan, out of hours MRI scan. The second one is a bladder scan. More and more the bladder scan, especially pre and post vital volume, but most importantly the post vital volume, you are using more and more as an adjunct or a suspected cauda syndrome. There has been various meta-analysis and various paper has been published with the PVR residual. You can see 100, 200, 500, and definitely as the volume goes up, the PVR, the predictive value goes up and up. A paper from Nottingham by Mike Trevitt and Magnum had made the cutoff point of 200 ml. If the patient has got a PVR of less than 200 ml, you can see the negative predictive value is almost 97%. So there is a very small chance of those patients having a cauda syndrome. But we also remember that one, that bladder scan is very much an operator dependent tool. So be aware of that. Now comes to treatment. There is no controversy regarding the treatment modalities. We all agree the patient needs a surgical decompression. But two things regarding surgery. Number one is the timing of surgery. When this patient needs to be operated, we'll come into in the next slide. And the mode of decompression. Some people do laminotomy, either unilateral or bilateral. Some people do a wide laminectomy for the chordaequina decompression. But whatever you do is a personal practice, but you make sure that you identify the nerve root. They are so severely stretched by the big prolapse disc. Before you do discectomy, you must identify the nerve root and the thecal sac. Okay. And the second thing is that sometimes a couple of studies has showed that even you've got a large disc, those can be managed conservatively unless they have got any signs of chordaequina syndrome. Now, the several meta-analysis has been published regarding the timing of surgery. Karzovic, about 20 years ago, published the first meta-analysis that showed that they should be operated within first 48 hours, and the outcome is better. If the patient operated after 48 hours, the outcome is not good. But the finding of this paper was later kind of an challenge. And another meta-analysis in 2008, I forgot the name to be honest, that showed that we cannot analyze the CSI patient with the CESR patient. So they are kind of a totally different entity, and they should be analyzed in a different separate patient group, because there's much to lose in CESI patient than CESR patient. And Mr. Todd, one of my boss from Newcastle, he has done a lot of work in chordaequina syndrome, we all know, and he published this paper, and that clearly said the longer the chordaequina nerve roots are compressed, the greater the harm and the poorer the extent of the recovery. So that is the principle. And so there should be a prompt diagnosis of chordaequina syndrome, and there should be a prompt decompression of the chordaequina syndrome. But the key word is practically possible. So what the BIOS say regarding timing of surgery? Unfortunately, BIOS doesn't give any time frame, but what they say, nothing to be gained by delaying surgery, but potentially much to be lost. And they also say decompression at the earliest opportunity, but again, depending on the duration of the symptoms. One thing in this respect, I must emphasize that one, that up to 25% of patients of CESI that impending, they may go into retention and CESR in the 24-hour if we don't operate. So there's a lot to lose waiting on this CESI patient. So outcome. The outcome of chordaequina syndrome is difficult to assess because various studies has given a varying diagnostic criteria and different points of outcome. And it is also itself is a very complex procedure. But there is no doubt, remember that, or there is no doubt that CESI patient at the time of surgery has a much better prognosis those with CESR patient. So again, the CESI patient has got much better prognosis. If you see, about 90% of CESI patient, if operated within 24 hours, has normal or acceptable bladder bowel function. It goes down to 40% if they are operated 48 hours. But remember this 24 and 48 hours is from the onset of the symptoms, not at the presentation to the hospital. And CESR has a less predictable outcome, and various papers quoted 20 to 80% of bladder bowel recovery. But as a whole, up to 75% of patients of all CES patients, there's no classification, they will have some form of eventually acceptable urological function. But up to 20% of CES patients will have poor outcome, and they will need some form of ongoing treatment, self-catheterization, colostomy, spine injury rehab, social rehab, those factors. So prognosis. Prognosis has multifactorial, all know, but in case of chordaequina syndrome, these three factors I think is the most important one. The neurological condition at presentation. Second is the duration of symptoms, how long the patient has the symptoms from, and also progression of the symptoms. It also implies with the duration, but if a patient presents acutely 3 hours of symptoms, there is more to lose by delaying those patient diagnosis and surgery. Some medical legal implications. Unfortunately, it is one of the most common spinal condition where there is successful claim against a doctor. So there's a various reasons: delay in diagnosis, delay in investigations, delay in performing surgery, or even complications during surgery. Not all of them implies to the orthopedic surgeon. A&E, GP has also been guilty on this one, but be aware of the medical legal implication of Gardner-Wells syndrome. And when it comes to an orthopedic rage or an on-call consultant or neurosurgical rage, we always give advice over the telephone regarding Gardner-Wells syndrome, whether the patient needs to be scanned or not to be scanned. So when you give advice, be clear and precise regarding the red flag signs and document that one, what advice you have given. Sometimes we consent for the surgery. We have a discussion with the patient and describe the risk of surgery. And also, most importantly, what you are trying to achieve for the surgery. It is the goal of the surgery to preserve function. So there might be some deterioration, there might be some improvement of the symptoms, but the main goal to preserve whatever function they have got at the moment. Surgery in the middle of the night, it is out of hour surgery. It is also a very controversial issue. As a trainee, I used to operate Gardner-Wells syndrome at 3 o'clock, 4 o'clock in the morning. Again, the unit to unit policy varies. But have you got a good outcome operating middle of the night? Your tiredness, surgeon's skill, the skills of the operating theater department nurses. So again, it depends on the local policy and also the presentation of the patient. If a patient, a young patient comes with CESI, personally, I will operate whenever it is, because there's up to 25% of patient may become to retention if you want to delay the surgery. And again, most importantly, please document clearly in the notes why you have made a decision and what are the reasons rationally making that decision. So in summary, proper history taking, proper clinical examination, but be aware of the low predictive value. Investigation, again, the bladder scan might be a very good adjunct for requesting MRI scan, especially during the out of hours MRI scan. Documentation and explanation to the patient, and also explain any reason for delay. Again, is a nice chart I have taken from Mr. Qurashi's presentation from last year, and it's from again from an article from Mr. Todd. If someone has got a large disc but unilateral radiculopathy, we can take and watchful wait, but warn them about the features of Gardner-Wells syndrome. Someone has got suspected Gardner-Wells syndrome, bilateral radiculopathy, is a watchful wait, but warn about red flag sign. But in my personal opinion, that I should intervene in those patients pretty soon, the next few days on my next list of my list. Don't wait kind of a watchful wait of those patients. The CESI, again, this is the most important group to lose. So they should be operated urgently to my practice whenever possible. CESR, the patient went to retention. So in those patients, we should be operated in the same day in the emergency list. But unfortunately, the CES who has lost all the function, but again, depends on the duration of the symptoms. The most important thing, the duration of the symptoms onset, they should be operated in the same day or in the next morning. Thank you. Thank you.
Thank you very much, Faisal. I think that was a very good coverage of the whole topic in very simple terms, and I think that will be very useful not only for the examinees, but also for some of our colleagues. I'd like to now invite my good friend and colleague, Simon Hughes, who's very passionate also, not only about surgical care, but also about teaching. In fact, most of the time, he's always teaching somebody or the other, and he's always been supportive to BIOS and spoke in our last presentation as well, very well received. And I would be grateful if you could talk to us today about MSCCs, please. Thank you, Simon. And thank you, Faisal, again.
Morning, everyone. Many thanks for inviting me again to back to that.
No worries. In the meanwhile, I have a few questions in mind. Is there anyone else from the audience who would like to ask any questions for Matt or Faisal, please? Otherwise, I have a few questions in my mind.
Yeah. Shah, can you hear me? Sorry.
Yes, of course.
Yeah, I just sort of, I'm sorry, I had to join in a bit later because I couldn't get my audio working, but Matt and Faisal, who have given excellent talks, thank you so much for doing this morning for BIOS. Faisal, a question to you. I put it on the chat, but I think I shall repeat it here, that this condition of cauda equina is often managed by non-spinal colleagues of ours. And usually the patient pitches up late in the evening. In my hospital, out of hours MRI has been a very significant bone of contention of provision of this. And we have to refer to, say, our regional unit, which is King's. And the problem then arises, is this cauda equina or not? And the MRI becomes obviously the clear criterion to make that final decision. But is there something in your acumen that you would say that these clinical parameters suggest that this is a cauda equina more than likely, or something that one should not wait, and therefore the regional unit should take that on board and take the patient over rather than leave the patient in the local hospital cooking the next day for an MRI to be done?
It is, thanks for the question. It is a debatable issue. Unfortunately, we don't have any, as I mentioned in my presentation, there is no specific or single parameter which is predictive to cauda equina syndrome. But the loss of perianal sensation is the most favorable predictive outcome. And also, nowadays, we are using more and more the bladder scan, especially a post-voidal bladder scan. If there is a residue of more than 200 ml, there is a very, very good suspicion of a patient having some form of urological disturbance. It might be cauda equina syndrome, but MR might be negative. But if the PVR is more than 200, there is a very much suspicion of there's some form of urological disturbance going on. But we all know that up to only 10% to 15% of the patient who is suspected MRI scan will have a cauda equina syndrome. But right, unfortunately not.
Okay, so that's quite useful for everybody to know that saddle anesthesia and post-void retention, if it is, I think you mentioned that if it's less than 200 ml, that there's a 97%
of negative
predictive value.
Yeah, there's a paper from Nottingham. Yeah.
Yeah. No, thank you very much.
But my opinion is that one of my boss used to say that one, the missing one cauda equina is far less inexpensive than having 100 MRI scan.
Yes.
So I am, and I know there's opinion varies. Some of my colleagues is very strict. Oh, yeah, why you're referring this bullshit? Please pardon me. But my personal opinion that no, I don't want to miss a cauda equina and ruin a life rather than the radiographer coming in the middle of the night to having an MRI scan.
Yes, I mean, this is where the medical legal implications pile up for the surgeon under whose care the patient is technically under, but who has no real power to proceed with the treatment, even when it is suspected. And that's the problem. But thank you so much for giving
again is a kind of a clear documentation and discussion of the patient that this is the finding we have got. This is the neurosurgeon, spine surgeon saying, yeah, we'll see. It's kind of a two-way discussion with the patient. Will save a lot of trouble, even it is cauda equina syndrome.
Yes, thank you so much.
Welcome, sir.
Excellent. Okay, without further ado, I'd like to invite Simon to talk about his MSCC presentation, please. Thank you.
Hi guys, apologies about that. I'm on call and unfortunately the computer crashed. So great start, but anyway, very grateful for inviting me back to talk about metastatic spinal cord compression. I gave this talk, I think, last time we did this, and hopefully it was useful. Okay, I'm one of the tumour surgeons at the Royal Orthopaedic Hospital. There's 4 of us. These are the other guys, and we do primary sarcoma work and accept about 70 to 80% of the country. But we also do MSCC stuff, and I've got a real passion for it. Ultimately, this is a webinar designed to help you guys pass the exam. And in order to do so, you need to understand, obviously have the knowledge to pass the exam, but understand, I guess, the raison d'etre for the exam, as well as the psychology of the examiners. Now, basically, the raison d'etre of this exam is such that you can pass the FRCS to become a consultant. And that doesn't mean to say you need to be a spinal surgeon to treat MSCC. Obviously, you need to be or have the knowledge to be a day 1 or trauma and orthopedic consultant. So that's the whole reason for the exam, obviously. But the psychology of the examiners is important as well. Your opening gambit is extremely important in any exam. And basically, when you're asked to define MSCC, you cannot waffle at the beginning. MSCC is simply the compression of the spinal cord, cauda equina, or the spinal nerve roots by bone or soft tissue as a result of malignant infiltration. But in plain English, MSCC is where tumour is spread, typically to the spine, and is causing compression to the neurological elements. You cannot have MSCC, though, if the neurological elements are not being compressed. Okay. So what can the compression come from? Well, it can be a combination of bone versus soft tissue, or a combination, or both of, obviously. The compression, though, may well be from non-malignant tissue, i.e., for instance, retropulsed bone fragments in the cases of pathological fractures secondary to metastatic disease. And remember, indeed, that in fact, some of the lesions can be expansive, particularly those that are sclerotic in nature, such as prostate. So where are the primary sites coming from? Again, this is something where your opening gambit has to be clear to that question in the exam. The primary sites are typically breast, prostate, lung, renal, thyroid, and myeloma. But how are you going to remember that? Well, yeah, rule of 2 is there's 2 breasts, 2 lobes to the thyroid, 2 lungs, 2 breasts, 2 lobes to the prostate, 2 kidneys. And then obviously you've got your other ones like myeloma. When I talk about cancer to patients, I normally tell them, look, it's not particularly useful description, cancer, lesion, tumour. You're more interested in what the actual diagnosis is. It's a bit like the word car crash to a car insurance company. It can mean anything from a 2-mile-an-hour crash in Sainsbury's into a shopping trolley to 130 miles an hour on the M6. These 2 things are poles apart. And it's the same with the word cancer. You're more interested in what it is, how aggressive it is, and how likely it is to respond to treatment. I typically think of cancers in 3 kind of scenarios, or 3 boxes. The first box is the carcinoma. These are your cell linings. This is where something has gone wrong with the linings, or the cell linings, sorry, and these are the ones we've all heard about. Then you've got your hematological ones, like your myelomas and lymphomas. And the reason why I separate them from your carcinomas is because you don't see them on scan so well. Remember, blood is not an organ in the same way that, or blood is not a visceral organ in the same way that breast, lung, etc. is. And then thirdly, you've got your weird and wonderful stuff like your sarcomas. But in the back of your mind, every time you see a patient with MSCC or with cord compression due to malignancy, should I say, always be suspicious of whether or not this could in fact be a primary, because the treatment regime is very, very different with very different outcomes. So how do these typically present? A lot of the time, these patients have a history of cancer in the past, and that's a red flag in itself as far as I'm concerned during a history. If someone says this chap's got prostate cancer 15 years ago and he's now got back pain, to my mind, he has prostate cancer in his spine until you prove to me that he doesn't. Beware of those ones where they tell you that they've been cured before, etc. Breast, for instance, particular, can come back at a later stage. Spinal mets are sometimes diagnosed at initial staging as well, i.e. the patient has rocked up to A&E or the GP for the first time with back pain, and that's when we find out they've got spinal mets, i.e. they have a diagnosis that is unknown as to where the primary is just now. And that's where your cancer of unknown primary referrals are important. And as we said, spinal mets, they can be that first presentation of malignancy. Some of the papers quoting between 6 and 20%, and in surgical time, or surgical patients rather, where we're getting referred them, it can be up to 40%. But beware, as I said, 8% of these, according to the papers, can be a primary cancer, or a primary spinal tumour. So what are the clinical symptoms? Well, sometimes nothing. This is an incidental finding sometimes because someone's gone in with a chest infection, for instance, they've had a CT scan, whatever, and it's proven that they've got mets on the spine. Often the patients will have pain or indeed neurology. But remember, we are orthopedic surgeons or spinal surgeons or neurosurgeons or whatever that may be, but we are still doctors. It is not appropriate to refer patients when they have not been dealt or dealt with appropriately, for instance, in times where they are hypercalcemic and acutely unwell. You need to treat that first, and that can be extremely dangerous. So look at the patient as a whole, not just as a scan. Sphincter dysfunction alone is actually pretty rare, to be honest. Red flags, look, we know this. I teach medical students regularly this. We all know the red flags, but you would be surprised the number of times when you delve into someone's history that they did have red flags, and in fact, they had it on numerous occasions prior to this presentation and they were missed. If you have pain in the middle of your thoracic spine and it is unremitting, as far as I'm concerned, you have a spinal tumor in your thoracic spine until you prove to me they don't. If you've got progressive spinal pain, that is worrying. If it's severe and unremitting, that's worrying. If it's aggravated by straining, if you've got tenderness, if you've got nighttime disturbance, look, these things are all worrying, and you need to look into that. You cannot fob that patient off and say, well, it's musculoskeletal, off you go. They need imaging and they need a diagnosis. Be careful about patients who tell you that they've got long-standing back pain. 80% of the population will see their GP at some point in their lifetime with back pain. That's a more common presentation to the GPs than the flu. So be careful about that, because lots of us get back pain. But you want to sieve through those patients and make sure you're not missing the one with metastatic disease. So for instance, in this case here, this is a patient who's in her 60s. She's got long-standing neck pain because she worked in a factory. She's bent over a long time. She normally has a degree of a kyphosis, I guess, in her thoracic spine. But in fact, that's why this got missed for a while, because, oh, okay, fine, you've got degenerative neck pain, that's fine, off you go, off you go. But in fact, she turns out to have metastatic disease in her spine. So we've got to keep a very close eye on these patients and have a very low threshold for investigating them. So how do we assess them? Again, medical school stuff, but again, it's so important in the exam, particularly in the FRCS. The history gives you 95% of what you need to know. But the history is clear. It is not back pain, cancer, refer to spinal surgeons. It is a proper, thorough history indicating what the pain patterns are and the appropriate timings. Referring in the middle of the night for someone who's been paraplegic for 6 weeks doesn't help, but referring in the middle of the night when someone's gone off that day is imperative. Leaving it till the next morning to refer to the spinal team is not appropriate. Again, beware of the systemic symptoms of the patients as well. Again, if someone is acutely hypercalcemic and they are unwell, you need to deal with that first. The examination, again, remember, this is slightly different where we talk about the joint above and below in orthopedics and trauma. In metastatic disease, this is a systemic upset to that patient. They require an overall body examination, and particularly if they have not been diagnosed with cancer before, you need to try and find out where that's coming from. So you need to examine the possible primary sites, such as thyroid, good examination of the chest, breasts, axillary lymph nodes, groin, abdomen, etc. You must do that. And a neurological assessment is imperative, and that must be done properly. I'm sure we all get fed up with referrals at times from A&E, etc., with due respect, saying things like, well, this patient's got back pain. Well, that's the equivalent of phoning up the cardiologist and saying someone's got chest pain. I don't know anything about it, though. I don't know where it is. I don't know how it's radiating, how bad it is out of 10, what's making it better and worse, precipitating, aggregating factors. But you must do that. And the neurological assessment is imperative. It's a proper MRC power grade, in the lower limbs, L2 hip flexion, L3 knee extension, L4 ankle dorsiflexion, L5 VHL, S1 plantar flexion, because we need to know that data in order for us to appropriately make the management plan for the patient. And a PR examination is essential. They used to say, if you don't put your finger in it, you'll put your foot in it. Assessment of spinal disease. Look, yeah, okay, once we've done the history and examination, we organise a battery of investigations based on what we think the differential diagnosis is. But things that we're looking out for, why we're doing these investigations, is to work out, is there actual or impending fractures? Is there actual or impending neurological compression? And also, what's the overall disease burden of this patient, both in the spine and throughout the body as a whole? So how do we go about doing that? Yeah, okay, you can do a bone scan. It's less in favour these days because they're reasonably non-specific, and you need to be very careful about false negatives, such as in myeloma, renal, or those tumours that are super aggressive and you get far more lysis than you get any blastic activity. So here's a bone scan here. You can see that around L3, it's not a lot to see, to be honest, But yeah, that's what was found, renal cell carcinoma on the CT and MRI. MRI, this is our gold standard investigation, okay? When I started as a medical student a long time ago, getting an MRI scan was a big deal. Now, as far as I'm concerned, it's a bog standard investigation that every single spinal patient requires. And essentially, we're looking at the T1 and T2 weighted images, as well as star sequences. And you can do fancy ones now, like in-out phase, etc., to look at fat deposition and work out whether or not lesions in the spine are in fact malignant. But the main thing to say in the exam is the patient requires a whole spine MRI scan. There is no point in operating in the lumbar spine for someone who's riddled with cancer higher up and in fact has instability in the neck, for instance. They require a whole spine MRI. And axial images through any significant collapse or epidural tumour is a must. You'll get asked in the exam, maybe even in the basic science questions, tell me how different pathologies look on different imaging. Remember, tumour is low signal on T1, higher on T2, and always look out for the soft tissue extension as well, okay? Common question or a common fear amongst trainees when I do viving for practice viving for the FRCS is, look, how quickly should we get an MRI? And the answer is 2 words: common sense. If the patient's pitched up and they've got back pain and it's been like this for 2 months, 3 months, and they have no neurology, then yes, they need an MRI scan, but it doesn't need to be done immediately. But remember, those patients have to, you have to give them the appropriate warning such that if they develop any symptoms, they know what to do. And you need to document that both to cover the patient and also to cover yourself. If you're talking about definitive treatment for a patient with MSCC, then you're looking at an MRI within 24 hours. But as far as I'm concerned, if they've developed neurology and they're going off their legs, the MRI, the sooner the better. The simple reason for that is because you want to operate and you've got to be aware of what's going on. I've put down here, out of hours, MRI should only be performed when there's a real emergency need and you have an intention to proceed immediately to treatment. That's fine in certain situations, i.e. you're in a hospital that is all singing, all dancing with spinal surgeons, etc. But let's say, for instance, you may be in a district general hospital and you're referring to us here at the Royal Orthopaedic Hospital. I don't have medical cover here, for instance, in the same way that some of the level 3 trauma centres do, etc. So it's more a question of working out what is the best logistically for this patient and how can we go about it. But the sooner the better is basically the answer I would want to hear. This is an MRI scan of a patient with breast cancer. In fact, she's had previous mets to the cervical spine. She's been treated with radiotherapy, but she's complaining of increasing mechanical low back pain, but has a normal examination. You've got to be careful with these patients because, again, you can say, well, you're in your 60s and 70s. Of course, you've got a bit of musculoskeletal back pain, all the best. But in fact, when they've got that history of cancer, your threshold for investigating these patients should be far lower, and you should be basically organising scans. CT scans, look, CT scans are really important for 2 reasons. First and foremost, for staging. It's all very well having cancer on the spine, but we know that 95% of the time when someone has cancer on the spine, it is a malignancy that is metastatic, i.e. it is spread from somewhere else. If that's the case, we need to know where, and also if it's spread to the spine, then where else is it spread to? That gives you the staging of the tumour. Grading and staging are 2 very important concepts, and in order to pass the exam, you've got to understand them. Staging is working out where else is the tumour. Grading is effectively working out the aggressiveness of the tumour, okay? Staging, CT, chest, abdo, pelvis is your bog standard examination. You're looking at, as I said, where else is the tumour. The second reason, though, why CT scans are useful to me as a spinal tumour surgeon is I want to know sagittal and coronal reconstructions of the spine to determine what the stability of the spine is, and also to assist in planning my surgery going forwards in terms of pedicle screw placements and whether or not any other surgical treatments are required, such as an anterior construct, etc. So here we have renal met at L3 and the CT scan showing that as well. You can see that you get different definitions. The MRI scan is great for the soft tissue. CT scan gives you an idea as the lysis. Once you've done those investigations, you've done the history, you've done the examination, you've come up with a list of differential diagnoses, you've employed a battery of investigations to work out which of your differentials is your diagnosis, and you've now made it. And the patient now has, for instance, metastatic lung cancer spread to the spine. Who are you going to speak to? there's a lot of debate about this in the country. When I was in Oxford, basically you had to speak to the oncologist, and then the oncologist would refer to us as the spinal team if they deemed this to be appropriate. In different regions, such as in ours in Birmingham, for the metastatic stuff anyway, the referral typically goes to spines first, and we make that decision. But the MSCC guidelines from NICE are very clear. You must seek advice from the oncologists to determine what this patient's prognosis is. The reason for that is very straightforward. If someone has cancer that has gone everywhere in their body and it is unresponsive, or they have a cancer for a long time now and they've utilized first, second, and third line treatments, and there's not a lot else, more wiggle room for the oncologists to work their magic, the honest answer is that patient is probably not a suitable surgical candidate on the grounds that the prognosis is, say, less than 3 months. The last thing you want to do is operate on someone who has 3 months left on this earth, that takes them 6 to 8 weeks to get over the operation of which they've had no real benefit from. And during that, they've been stuck in a hospital bed and been unable to be, particularly in COVID times, unable to be in contact with their family, which is extremely important to give them that dignified death. If, however, their prognosis is pretty good, the last thing you want to do is label them as a, in inverted commas, cancer victim and say, well, look, you're not for any surgery because everyone's got to die of something, and all the best. Because if that patient then loses bladder and bowel function and they're stuck in bed, you've now committed that patient to an undignified death as far as I'm concerned, because they're now lying incontinent of bladder and bowel and unable to get up. That's not appropriate. So I think the main thing with this slide is you should refer to both. And the reason for that is because, yes, sure, if non-surgical treatment is best, the oncologist will still want to know about whether or not the spine is stable, and that requires typically a spinal surgeon to tell them that. And if they are for surgery, then I need reassurance that, in fact, this prognosis is good enough to justify the surgical intervention for this particular patient. If we are going for surgery, though, well, yeah, I want to know the prognosis, and we've spoken about that, and that requires a detailed history as to what the staging of the current situation is, i.e. have they done an up-to-date CTAP scan, and what's the treatment to date. That's particularly important with patients such as ones who are on chemotherapy or have been on chemotherapy. Are they currently immunocompromised? In addition, if they've had radiotherapy before, that's extremely important, because operating through a field that's had radiotherapy treatment and, perhaps 70 grays, for instance, that's fraught with difficulties, and your complication rate is much higher. And on those grounds, you have to be appropriately consenting the patient as such. You want to know what the stability is, and typically that'll be from the imaging. And as well as that, you want to know what the neurodeficit is and the duration of that. You want to know what their adjuvant treatments are, and we've discussed that already. What their past medical history is. Is this a patient, for instance, that's actually fit for surgery? And last, but by no means least, what is the patient's wishes here? If they do not want surgery and they're appropriately consented, they're of sound mind, you cannot make them have surgery, okay? And there is no point in going through a battery of investigations there afterwards if they're never going to be for surgery because the patient is adamant in their own minds that they do not want to proceed. SIN score is very useful, and you might get asked this in the exam. It's based typically on CT images, but in fact, there's been a recent paper published from Birmingham suggesting that you can now do that through MRI, which is great. But the SIN score is based from 0 to 18. The first 1/3 is stable, the second 1/3 is potentially unstable, and the last 1/3 is unstable. And it's based on these 6 different parameters. Now, the honest answer is much of it is common sense, but it does give you a good flavour sometimes as to whether or not you should be operating or whether or not you should not be. I have to admit, I've perhaps got a slightly skewed view, because I think the majority of the time I see patients, and my colleagues do, we're typically seeing them in that 7 to 12 range anyway, but it can be at times very useful to give advice back to the oncologist that, like, this in fact is stable based on this SIN score, based on the imaging, and we don't have to do anything. So here you can see CT scan of the cervical upper thoracic spine. You can see that it's junctional, this tumour kicking around here. This is very painful by the looks of things, and it was when we asked the patient. It's a lytic lesion. There's already got a degree of subluxation, kyphosis, etc. there, and there's greater than 50% collapse with bilateral posterolateral involvement. As you can see, it's a high score. Therefore, probably needs, if appropriate in terms of the patient's parameters, surgical stabilization. Here's another CT scan, L4 lesion, You can calculate there, it's 10. Okay, it's potentially unstable. This is someone that I'd probably want to review and ask them, look, this is what surgery would involve. What do you think? Do you want it? And how bad actually are you? Other other investigations we can do. PET CT scan. Okay, now PET scans are useful if you have an FDG avid positive tumor and you can determine whether or not there's any evidence of disease elsewhere. Effectively, it's more useful for staging. At times, that can be very useful, particularly in oligometastases, i.e. one metastatic deposit present within the spine, or indeed in primary tumors, because it can give us an idea as to whether or not there's a potential for curative excision here. Angiography is extremely useful as well. Patients, particularly with GCTs, which is a form of primary spinal tumor, giant cell tumor, but those malignant ones like renal and thyroid, you must have a very, very low threshold for getting them embolized. We've seen patients bleed to death, unfortunately, with these, even from simple biopsies, on account of the huge volume of blood that goes through them. The initial management of these patients, if you're seeing this patient on call, for instance, and bearing in mind that's the whole, apologies for that, sorry. The initial management of these patients, if you're seeing them on call, and remember, that's the whole point of the FRCS. You're a day one consultant. This is the patient pitching up to you in saying elsewhere. First and foremost, suspect it. Investigate them and admit them. Do not send someone home with MSCC. I guarantee you the lawyers will have a field day with you. Bed rest until stability is determined and get senior review. Now, in the FRCS, they'll always say to you, but you are the senior, so what are you going to do? But anyway, you get an MRI whole spine and you get the results. You get a CT, thorax, abdomen, pelvis, and you stage the tumor and you get the results. Now, some of you are thinking, why does it keep going on about this getting results? The reason is you'd be surprised the number of people who fill out the form, MRI whole spine, boom, there you go, we'll see you tomorrow. Waste of time. That's the equivalent of looking at a septic arthritis patient and saying, we're going to do some blood tests on you, white cell count, etc., CRP, and I'll see you tomorrow morning on the ward round. Doesn't work. Oncology input is essential, remember, for those two reasons. Are they suitable for surgery? Well, we need to know the prognosis. If they're not suitable for surgery, the oncologist will still want to know what the stability is and discuss with the local MSCC coordinator ASAP. If you're referring to another hospital, you must get an anaesthetic assessment, typically because you want to know that this patient's fit and well for reasonably big surgery, shall we say. Do not forget the basics though, okay? Spinal observations are imperative. It's all very well seeing someone at 11 p.m. in A&E and saying, well, you look okay, your neurology is pretty stable, but actually if they drop during the night, you don't want to find that 8 o'clock tomorrow morning. So they should be getting regular spinal observations, and beware of those patients, in my opinion anyway, who are not on orthopedic or spinal wards, because in medical wards, things proceed at different rates, shall we say. Vte prophylaxis is essential. Remember, if you've got cancer on board, your risk of having a venous thromboembolism is significantly higher. You should be on mechanical prophylaxis like TEDs and SCDs, but be careful with chemical prophylaxis, particularly if the patient is due for imminent surgery, because again, you don't want to effectively anticoagulate them and increase the bleeding risk. Pressure area care, respiratory care, bladder bowel care, all of these are essential. GI protection. Reason why I mentioned GI protection is because if you're giving the patients dexamethasone steroids, then you've got to make sure they've got PPI cover for that as well, okay? Evidence for steroids in metastatic spinal cord compression. If you look at Kumar's patient in 2017, Kumar's paper, sorry, in 2017, there is limited evidence. And there is no role for it in the absence of MSCC, i.e. Mrs. McGlumford here has breast cancer at L3, but there's no cord compression. She does not need steroids. If there is cord compression, she perhaps does. I think in the presence of MSCC without clinical symptoms, I'd probably defer steroids, but if they have clinical symptoms, i.e. neurology and pain, etc., I would be sticking them on steroids. The one caveat to that is lymphoma. If you're suspicious of lymphoma in the spine and your radiologist tells you it might be, please don't give them steroids, or certainly discuss it with your local spinal team, because you can effectively get rid of the disease quite quickly with steroids, but that makes it more difficult later to actually make the diagnosis because there's nothing left to biopsy. These days, cancer has moved on considerably. When I do the sarcoma MDTs, both regionally and nationally, the talk is completely different from even 5 years ago. When you look at genetics and the markers of these cancers, you know, at medical school a long time ago, they'd bring in 3 patients. These are 3 women, they've all got breast cancer. They don't. One's BRCA positive, one's HER2 receptor negative, the other one is going to be, you know, a phylloides tumor. They're all breast cancer, but they're totally different. So these genetic markers are imperative these days because they give us a much better idea as to the treatment regimes that the patient is likely to be successful with, as well as what their likely prognostic or prognosis is going to be. So they have huge prognostic value. Here in Birmingham, we're sending all our tumours off now to the 100,000 Genome Project, which is helping considerably in mapping out the genetics of these tumours. Ultimately, the patient turns around to you and says, thanks very much. You've mentioned to me that I've got cancer on board in my spine. I'm at risk of becoming paralysed just now. And now you're talking about the risks of surgery, Mr. Hughes, and thanks for that. But you've mentioned things like paralysis, mortality. You know, that sounds horrendous. So I take it it's worth going through this surgery because you're going to cure me. And the answer very clearly is, I'm not going to cure you of this tumour, because it is metastatic and is spreading from somewhere else. You need to be crystal clear with the patients with that, because none of us would go through operations most of the time when you heard things like paralysis and mortality. But you need to be very careful with the patients and clear with them that we're doing this in order to improve your prognosis, improve your current neurology and your current clinical status. But I am not improving typically your prognosis, and definitely I'm not curing you. Patchell's paper in 2005 was really useful. They had roughly 100 patients. They split them up into surgery and radiotherapy, and they realised that the ones with surgery walked for far longer and they had less analgesic use. So if you look at that, they were walking at 122 days versus only 13 days with radiotherapy. Just to be clear on this, radiotherapy can help deal with the tumour, but it does not improve instability in the spine. It's like woodworm in a wooden house. You can gas the woodworm and the woodworm die off, and that's great, but the damage they've already caused is still there, and the risk of the house falling down is still there. So you have to be very careful with those patients and still say to them, look, you may well require surgical stabilization despite this. The surgical strategy is very clear. It's basically to restore or maintain the biomechanical stability. It's to protect the remaining neurological function and hope that you will definitely prevent that from getting worse, but at the same time, maybe improve you. But there is no guarantees. And again, you need to be crystal clear with the consent with the patients here. There is no value if the patient is paraplegic more than 24 hours, in my opinion. That's a sweeping statement, but globally that holds true. Does it improve the prognosis? Difficult to measure. The reason why it's difficult to measure is because, yes, you've got prostate cancer on the back, and yes, I've operated on you, and yes, I'm not curing you of this, but had you become paralysed, your morbidity and mortality rate would skyrocket, because we all know lying in bed is not good. So it does improve the prognosis from that perspective. Surgery ultimately treats the complications of the disease, but not the actual disease in the majority. You need to be clear with these patients that you are dealing with a secondary phenomenon, and that the primary problem, i.e. the disease, needs to be treated by the oncologists going forwards. SABR can be useful as well. This is stereotactic beam radiotherapy. They might ask you about Bilski's classification in the exam, but ultimately, if you've got tumour pressing directly against the spinal cord or the cauda equina, and you ask your oncologist, radiation oncologists, to give you radiotherapy, they will tell you, look, I'll try my best, but I won't be able to give a sufficient dose here without damaging the cord itself. So sometimes we will go in there and we'll perform separation surgery such that we get rid of the tumour, particularly in the epidural compartment, and allow the cord or cauda equina to be free, such that you can increase the dose of radiotherapy and get the patient a decent treatment. To 2/3. Vertebroplasty is essentially what I call putting polyfiller into bones. I think it's a bit more expensive than that. My radiology colleagues are not too happy to hear that, but you know what I mean. This is useful essentially in cases where you have collapse of the bone due to tumour presence within there. or pain, for instance, and you think, this patient's not particularly great for a big surgical operation, but vertebroplasty can be useful. It has limited morbidity, but beware, it's not risk-free. I have seen cement leaking back into the canal such that I've had to go back in and operate, or indeed actually cement managing to get into the venous system and causing emboli. It's suitable for patients with perhaps shorter life expectancies, and also can be used as an adjuvant to traditional open surgery. If you're transferring the patient for care, and beware that, you know, if this comes up in the FRCS5 and they will be asking you about this, you've got to be clear about those things that I mentioned earlier: patient's wishes, staging, current clinical symptomatology, etc. But always consider the patient's wishes, always check their prognosis, always check the neurostatus, understand the disease extent, and then get the imaging and get that transferred across. In summary, look, have a high index of suspicion for MSCC, and beware of changes in those pain patterns, remembering that a huge number of the population will have back pain at some point during their life. Get the appropriate imaging, but understand that there are limits with that. Remember, just because you've got a sclerotic bone met doesn't mean to say that the bone is actually strong. If you've got prostate cancer and you've got sclerotic mets, I always give the analogy to these patients. It's a bit like a dodgy builder. They've turned up, they've done a botched job, and they've done it quickly, i.e. the bone has been built by the tumour, but it's not of good quality, and you've got to be careful that you're not ruling out that that is in fact at risk of fracturing. And always remember, it's much better to prevent deterioration rather than to react to it. It's much easier to fix a car that hasn't yet broken down. That's how I look at these MSCC patients. So once again, apologies for the delay there. Has anyone got any questions?
Yeah, that's great. What I'll do is we'll ask one quick question each, just in terms of fairness. I'll start with Matt Sewell. For example, Matt, if you had to take a patient back to theatre for a reduction of a dislocation, would you do that awake or with the patient asleep?
So I think it depends on the neurology and, as I say, practicalities. So if you had a cervical dislocation and the patient was fully paralyzed, so Asia A, then it doesn't really matter. You're not going to make the patient worse. You know you're going to have to stabilize it. So I think it's perfectly reasonable to take the patient to theatre at some point. This doesn't have to be urgent, it can be the following day, to reduce with traction and then stabilize effectively. If the patient is a different beast, if the patient is not paralyzed fully, so they have an incomplete injury, because in theory, you can make the patient worse by reducing the dislocation. So you then have to make a judgment. Do I want to take the patient to theatre immediately or the following day? There's no guidelines, the sooner the better, but it's perfectly reasonable in the middle of the night to delay it till the following morning. So in that situation, my advice would be to say that you'll apply cervical tongs on the ward and assess the neurology regularly. If the patient gets neurologically worse, you would reduce the amount of weight on the traction and reassess the neurology. The patient's neurology does not improve, then you'd have to take the patient pretty much straight away to theatre for a reduction. Why would the neurology get worse? Well, the assumption is that a disc will have popped posteriorly, popping onto the cord. So you'd have to go in and fish it out surgically. So I think to keep it simple, if the patient is fully paralyzed, do it the following day. You can take the patient to theatre and apply the traction, reduce it and stabilize it. The patient's neurologically normal, I would probably place traction on the ward or leave the patient as they are during the night, assess neurology regularly. If there's no deterioration in neurology, then you can safely do your stabilization and decompression the following day. If there's a deterioration of neurology on the ward, then you're sort of duty bound to do something about that, which could either mean reducing traction if you've applied traction on the ward, or taking the patient to theatre and fishing out the disc with a reduction, stabilization and decompression in the operating theatre.
That's great, man. Thank you very much. Quick question to Faisal. I think this is being discussed. This is from Ash Khurana of Newport. He says, with regards to CSF, do you get overnight MRI scans for suspected patients or wait for early morning? I think we've answered that. What is the practice in your respective unit? I think you've said that already, having to common sense, depending on the situation, the length of duration of symptoms, and also the kind of presentation.
Yeah, yes. Yeah.
Does that answer your question, Ash? And one last one to Simon Hughes from which does radiotherapy cause destabilization of the spine, or can it cause?
The honest answer is radiotherapy cannot cause destabilization of the spine. It does not cause stabilization though, which I know sounds like a bit of a play on words. If you have some tumor within the spine that is effectively, for one, let's say plastic, whatever it may be, it's effectively causing pain in the bone, typically because it's eating the bone away, you can zap that with radiotherapy. And that's great, and it deals with the tumor, but it does not stabilize the spine itself. I think your question is probably, if you give radiotherapy, are you going to destabilize the spine? I would argue that whatever you're giving radiotherapy to is not giving stability to the spine anyway. So if it's a tumor, for instance, it will typically be soft anyway. It is not cortical bone in there causing a decent structure. It is something that's already been eaten away. So giving radiotherapy is not going to stabilize the spine, and it will not further destabilize the spine than you already had, if that makes sense.
Before I hand over to Mr. Tolat, our president, just want to thank all the panel members. I think this was a wonderful webinar. I'm not too worried about the not many numbers, because this is also going to be on YouTube and people can take advantage of it for years to come. Our previous webinar has a viewership of nearly 1,000 already, so that's not a problem. And I'm grateful to all the speakers. I'm grateful to all the attendees. And I just want to mention that our next talk is on the 14th of November on pediatric spine, run by Sunil Bajaj from Queen Elizabeth. Over to Mr. Tola, please. Thank you again.
Thank you all. Thank you, Shah, for the opportunity.
Yeah, hi everybody. I must say, I echo what Shah Nawaz has just said. I mean, this has been a fantastic webinar today. We support the webinars for trainees, and I think the webinar today has been particularly also useful for consultants who don't practice spinal surgery, as a very valuable update. So thank you guys all for spending your precious time on a Sunday morning teaching on this webinar. And I'd like to congratulate Shah for taking all the effort to do this. Thank you so much for this, and we'll keep in touch. Thank you very much.
Thank you all, and see you soon. Thank you.